appreciate everyone for taking the time and attending the meeting and seeing what's new with the state in the development of Marcus Alert as we implement. We all know that the code is for us to be fully implemented by 2028. So there has been a lot of movement and a lot to share for this fiscal year. So what I will do is go ahead and start sharing my screen. All right. Can everyone see this? If they could speak up because I can't hear you or I can't see you.
Yes.
We can.
Yes.
Perfect. All right. So my name's Emily Grassi. I'm sure as most of you have met in some capacity or another, I'm the Marcus Alert Coordinator for DBHDS. And here's our agenda for today. We have some state updates, a lot around data, a lot around the Marcus Alert training. We have a presentation from our Equity at Intercept Zero projects that is related to the Marcus Alert training. And then we also have our regional updates. I ask for everyone to save all of their questions for the end, and we can answer those at that time. Oops. Okay. So I'll start for DBHDS, our updates. We have some implementation updates that I will go into more depth on in the later slides about where we're at, how we're projecting, because of that timeline of needing to be fully implemented by 2028, what localities are scheduled to be implemented next, and a lot of other really important details. Aside from that, we have been working really hard on listening to feedbacks from localities that have already implemented and hearing some of their barriers. So we have attended conferences. We discussed both between myself or DBHDS and the Department of Criminal Justice. Are there any conferences that we want to put on for the state? How would that look like? What conferences do we need to attend out of state? Considering any kind of research or surveys from the state for feedback, particularly looking at ways that we can standardize some of the policies and procedures regarding Marcus Alert to improve implementation and how it intersects and connects with the rest of the crisis continuum. We also want to make sure that the already implemented sites feel supported. And so we're making sure that their local plans are being reviewed with the intention to have all 17 sites be fully approved. So we have just been doing a lot of reflection and listening and evaluating what the feedback has been from different localities. But I will turn it over to my DCJS partners to provide their updates for the state. Dallas, are you on the call?
Yeah, I was talking and still was muted.
Okay.
So as you can see at the bottom of this slide, the co-response grant for fiscal year 2025, the governor's office was gracious enough to give us $2.2 million of unspent money back to spend on Marcus Alert and CIT. And so our division decided that what we would do is put out a competitive grant for one-time funds for that $2.2 million. And that would be for localities that are currently doing co-response and localities that were attempting to stand up co-response in their locality. And that grant process just closed. It will go to the CJSB grant subcommittee on the 27th of this month. We have to meet with them and get their approval, and then it will go to the Criminal Justice Services Board on March the 13th. This money was restricted to law enforcement equipment. that would be used in co-response. So uniforms, unmarked cars, anything like that. Obviously, we weren't buying firearms, anything like that. So as it stands now, we will push out $608,596 to 12 jurisdictions that applied for the grant, and those 12, the number 12 also includes 2 state university police departments that are trying to stand up co-response or are currently doing co-response. That's all we have, Emily.
Great, thank you. Yeah, so it's going to be, it's exciting for some of the limitations within our budget for standing up co-response. So we'll see how that can make an impact and the expansion on co-response that will have. So as a reflection, this is where we are right now. These are the 17 sites that have already implemented. Just to give a brief snapshot of the various co-response compositions that they have. Some are clinician only, some are traditional clinician and law enforcement. And there's also, a lot of variation even in between what you see here. And I know our regional coordinators are going to go more in depth about each of these co-response teams, what they're doing, and some of the successes that they've had. But this is currently where we're at to date, a fully implemented site. As you can see for this on the screen right here for fiscal year 25, we were not granted any funds for new sites. So we are currently awaiting the final say-so for the amendment that was put through the General Assembly. They have came to, or the General Assembly has concluded that they would request for $4.8 million for fiscal year 26. And so that amendment would allow for the localities that were supposed to implement in fiscal year 25, and then some additions for fiscal year 26. And so this is also just a little bit more information on what that process looked like from beginning to end. The governor initially put out that he would like to support 1.2 in general funds to cover 2 additional crisis co-response. The House asked for 3.6 that would cover all the 6 sites that were scheduled for fiscal year 25. The Senate asked for even more, and they all met in the middle for 4.8. And so I put the links in here, and I can also put them in the chat afterwards for everyone to follow as it goes through. Right now, that is at the governor's desk for him to review and to sign off on or make any adjustments that he feels is necessary. So obviously that means that changes our implementation schedule. So for fiscal year 25, we had 6 CSBs scheduled to implement: Northwestern, Danville, Hanover, Portsmouth, Norfolk, and Chesapeake. And then for fiscal year 26, we had 9. So even with the budget that was passed by the General Assembly, I think we can all do the math and that there wouldn't be enough to cover everyone for fiscal year 25 and fiscal year 26. So how we proceed moving forward will be very dependent on what the governor decides. So we don't have any direction on what the scheduled implementation will be for the upcoming fiscal year or those after. But right now we know where the General Assembly ended, that it's in the governor's hand. And once we know that final approval, we will make sure that the appropriate steps are made to try to get everyone back on track. Again, I know that the regional coordinators are going to go in a little bit more depth, but even those that were scheduled for fiscal year 25, a lot of these CSBs are still working really hard, managing their implementation, the documents, the policies, and the procedures. And so, it's really exciting that everyone is still continuing on this work. And I think that we're all really hopeful about the upcoming years. So other updates, Marcus Alert with our data. We've had a lot of different updates and changes. Obviously, as we have more sites come on board, we have increased partners and more data. We're still, going through some data changes. We are almost finalized on the changes that we have made to the data sheet for PSAPs that they collect. And then we're also going to have the inclusion of co-response data. So the intent of that is to really paint a holistic picture of the crisis that, when they go through each of the Marcus Alert levels or our crisis system, and wanting to have a better understanding of what some of the barriers, what some of the successes and or challenges may be. And so we are really looking forward to having that inclusion and hopefully some more clarity that would be used for when we write our annual report, things for us to consider. And, as we're already looking and evaluating on ways that we can improve, that data will just help us even further. So as of right now, as I mentioned, we have not completed the steps necessary for these new data implementations, but I believe in the next couple of weeks that should be finalized. And the intention would be that all localities with co-response and then the PSAPs would begin in documenting this data beginning April 1st of 2025. I have already discussed with my data analyst and myself, and Bill and everyone else on the call, how we can support each of the communities. We recognize that this is a lot. Could be a heavy lift for some more than others. So the intention would be that before April 1st, we will host a regional information gathering where my data analyst or the data analyst and myself will go over each of the sheets and answer any questions and kind of give mock scenarios for everyone to feel comfortable and secure. Come April 1st, what's expected of them from the CSB side, what's expected of the PSAPs, and hopefully have a little bit smoother flow with collecting data as we go forward. That information will be given to everyone through the regional coordinators at DBHDS. So once we have the final approval and move forward, I will reach out to each of the coordinators, let them know, have them reach out to the various communities so we can schedule those times for everyone. And then again, the data submission for everyone to submit their reporting to, the email address is there below. And so, but we do have an example of the changes that we made. So the biggest change for the PSAP template was the flow. So it's easier to kind of flow through and it removes the error of clicking the wrong jurisdiction with your the rest of your data. In addition to that, we made some changes to include more robust call response options to really allow us to tie the co-response data in with the PSAP data collection. So we had to do a little cross-analysis to match on those ends. But this is just a snapshot of some of the data elements that we have changed and put into the data sheet. In addition, this is also a snapshot of the co-response data template. So these were where we had decided and landed on what we are going to ask our co-response teams to collect. So that will be PSAP, incident number, date of time or date of call, time, dispatch time cleared, Marcus alert level, understanding the various co-response compositions, the various behavioral health crises, whether or not the individual was under the influence, if there was ID or DD, and if so, was REACH contracted. Also highlighting on the reduction of injury in responding to behavioral health crises, and then basic demographic information. And then here is just a little snapshot from the data that we are currently collecting from our 911 call centers for the first and second quarter of the year. Sorry, I don't know why I was muted. This is not by region, but as a state as a whole. So naturally, with the first quarter of every fiscal year, we have sites onboarding for their implementation. And so it's common to see an increased call volume. So yeah, it just kind of breaks down what levels 911 call centers are engaging under the Marcus Alert Triage framework, and how are they dispatching. And so it seems that there's a lot of behavioral health led dispatches, and a lot of call volume. And then this is just kind of looking over time for the first quarter to see if there are any call trends. So it looks just, again, we would expect to see higher call volumes at the beginning of the quarter. But as they continue on in the fiscal year, they tend to even out. And then similar for the second quarter. So we are just kind of monitoring and trying to see trends and identify any barriers or successes. Again, it still seems to be pretty consistent to where CIT or a behavioral-led response is usually dispatched. And again, call time or calls over time for the second quarter. I would say with the election, that seems pretty normal around that time for November. And then right as the holidays and as the weather goes on, that we would see increase of calls in that time as well. All right, I will pass it along to Nikki and I think Reagan. They are going to provide everyone an update on their project for the Intercept at Equity at Intercept Zero.
Hi, everyone. So I'm Nikki Fadley, and I'm here with my Deputy Director, Reagan McManus, and we are with Strength in Peers. Emily, are you switching slides? Thank you. Do you want to switch again? Thanks. For those that are not familiar with Strength in Peers, we are a peer-run recovery community organization, meaning that we are all individuals in active recovery from substance use, mental health, and trauma-related challenges. And we provide a variety of services in our community for those who are struggling with those same types of challenges, everything from outreach, really a focus on outreach to individuals who are unhoused or coming out of incarceration, low income, underserved, rural populations. We do a lot of recovery programming, as you can imagine, led primarily with peer recovery support, but also incorporating case management, integrating some clinical services from partners. We have a few residential programs, a couple of sober living recovery houses, and a homeless medical respite house. And we just do a whole bunch of stuff out here. We're located in the city of Harrisonburg and also have an office in Shenandoah County and serve those two areas as well as the counties of Rockingham and Page. Switch next. This year actually is our 10-year anniversary. We're really excited, really proud about that. But since the beginning, since we were founded, our organization's focus and passion has been all about meeting people where they are and working with those individuals who are falling through the cracks and are struggling to get help through those traditional service providers and service models. We, as I mentioned, do a lot in the area of outreach, especially for those vulnerable populations. And a lot of that came from our own personal experience, as people in recovery who've had these kinds of struggles ourselves, we either experienced ourselves or saw in our friends and family members and other people we engaged with, that there are a lot of barriers to getting help, that there are struggles with the traditional service models. And so our organization and in creating our organization, we really had a focus on helping to create something different, an alternative service for those individuals. And that's what really has brought us to crisis work and wanting to be a part of the Marcus Alert. Switch. Yeah. So a couple years ago, at the beginning of 2022, we approached the Marcus Alert office about a project for developing crisis services, really in DBHDS Region 1, but really with the hopes that it could be a replicable model beyond that. And it's based on our years of experience offering peer support in our communities, as well as partnering with with counselors and psychiatrists to offer telehealth services for the participants in our programs. And the success of that model was our ability to engage those underserved populations and get them access to those clinical services that they were really having a hard time accessing. So we created the Compassionate Crisis Care Network with funding from the Equity at Intercept Zero grant. And it's really a partnership among recovery community organizations like ours and clinical partners, so that we would be able to accept referrals of individuals experiencing crisis or having, in recovery from a crisis, or to prevent somebody who's at risk for having a crisis, to be able to provide them services quickly, through a combination of that in-person, on-the-ground peer support and those clinical services that we partner with. Really meant to overcome barriers by having the local on-the-ground peer recovery specialists and the telehealth services working in conjunction. So we have we initially planned this with a one-year planning grant with almost all the CSBs in our region, along with the recovery community organizations, all helped us figure out what was needed, how to structure it, how to make it work. Also had collaboration with the DBHDS Region 1 Crisis Call Center out of Region 10 CSB. And where we are now is in implementation of this network. We have three peer-run organizations in our network: ourselves, Roads to Recovery in Lynchburg, and I'm Just Me Movement in Winchester. Each peer-run organization is serving kind of their geographic area. And then we have two counseling centers that are partnering in our project: the Harrisonburg Center for Relational Health, and out of Harrisonburg, of course, and the Arrow Project out of Stanton. And they are providing our participants assessment and then recommendations or referrals to other services, including peer support. We're also partnering with them for clinical supervision so that our services actually can be billable for those who have Medicaid. And we actually just had our Medicaid enrollment finalized last week. Yay. Our other partner is Concern Hotline, that's been operating a suicide prevention and crisis prevention warm line now for many, many decades, operated out of Winchester and serving a big chunk of Region 1. And they are working with us to be able to connect people who call the hotline to our network services as appropriate, and also be something that we can provide our network program participants as a resource if they need help after hours. This is just a quick copy of our flyer. So if anybody, maybe this is something we can send out to the group afterwards in case you have anywhere that this can be posted to provide people information about the services in the network.
As part of the project, we really identified a need for training of peer recovery specialists in crisis work. And we were fortunate enough that DBHDS Office of Recovery Services actually was coming up with an endorsement training called Crisis Service Training for Peer Supporters around the time that we were developing our Marcus Alert work. And they asked us to take on this curriculum that was developed by Recovery Innovations International, which was really developed in conjunction with SAMHSA's Crisis Now framework. And so we have been providing this crisis service training for over a year now. We have 100 graduates, peer recovery specialists and certified peer recovery specialists that have undergone this 3-day core crisis service training. It's been a statewide training I provided along with my colleague via Zoom, which allows us to kind of get our arms around a lot of peer recovery specialists throughout the state. We've had 13 train the trainer graduates that are certified to now deliver this curriculum. And we've created a monthly alumni group. So every month we come together and talk about the challenges that we're seeing in crisis settings where Marcus Alert is being built out. We use it as a platform for communication and understanding of what's happening throughout the state in crisis. And then we also created a crisis resource website, which actually lists all of the resources that we've been able to cultivate from participants in this core training that they are using within their own jurisdictions in terms of crisis resource connection. So it's been really beneficial in that way. Next slide, please, Emily. Just to give you a sense of the training that is involved and the topics that we discuss within this core training, we talk about our responsibilities of crisis services for a peer recovery specialist. We talk about the differences between warm lines and crisis lines so peers really understand who they're connecting to and why. We talk about the importance of becoming resource experts, really knowing what all of the alternatives are for recovery, knowing how to address certain circumstances and where we might be able to make a really good resource connection for someone that's hurting. We talk about the difference between crisis receiving centers and crisis stabilization units. We talk about peer support and hands-on work, what our responsibility is. We talk about no force first policy, seclusion and restraint, and what the peer recovery specialist role is or isn't in these crisis situations, and how to stay in our own lane given our work being very different from clinical providers' work and even law enforcement work. And so we talk about that in the class. We also look at the DSM and we really understand mental health conditions from a clinical language perspective. And then we redevelop it and talk about how we would talk about this amongst our peers. The way that we use peer language is very different than clinical language. So how do we define these big ideas and big words on diagnoses in a way that makes sense to someone when they're really hurting and have that feeling of hopelessness? We also talk about substance use and substance use in crisis intervention, and we talk a lot about trauma-informed care, our ethics, our peer recovery ethics, which come out of the state, and then also self-care, the need for self-care to avoid compassion fatigue and burnout. Next one, Emily. And we have upcoming crisis trainings. We tend to host these every other month. Our next one is in April. So this is a flyer here, and we'll send this out to Emily as well to
to send out to the group. But we do the crisis service training just about every other month. And then we also have another Train the Trainer coming up in April. So we cultivate from these crisis groups some experienced facilitators that can then take this curriculum out into their communities, especially in regions where Marcus Alert hasn't been developed yet. How are we providing some crisis service support for those areas? Okay, next. In tandem with this, we're developing an advanced curriculum. It's called the Compassionate Crisis Care Training. The purpose is to provide a higher level overview of crisis work in line with Marcus. The core crisis training that we've been doing is very base level. So this is more of an advanced training. We focus on prevention, intervention, and post-crisis services to talk about alternative means for addressing mental health and wellness of individuals experiencing crisis. So we want to look across that trajectory. Where can we be helpful, not hurtful? And some of the goals of this are to increase the capacity of the provider when encountering crisis, raise awareness regarding the complexities of crisis, that each crisis situation is unique, each person is unique, to examine traditional crisis response and to forge pathways to compassionate, what we are calling compassionate crisis care. Next, Emily. And so to give you a sense of how much more extensive this training is over the kind of baseline state training, we really talk about Marcus as peer recovery specialists. You know, this is a person-centered. We are consumers of crisis, have been in crisis ourselves. We talk a lot about Marcus and that particular crisis situation. When we talk about Marcus Alert, everybody goes, why is it called Marcus Alert? You know, we don't talk very much about the man. And so we want to do that in this curriculum and give peers an understanding of that situation, what happened. We go into prevention, where we really explore our own personal crisis, our relationship to personal crisis. We talk about empathy and the language of pain, which is really about suicide and why we come to suicide. What are the circumstances around that? We discuss adverse childhood experiences, and not just adverse childhood experiences, but positive childhood experiences. Where do we find our resilience? Where were the good moments? We talk about intervention, the 6 steps to intervening, defining crisis situation and trauma through a trauma-informed lens. We really break out the de-escalation loop, not just through language, but thinking about body language and tone and active listening, how we're using these things. We again talk about the appropriate provider intervention. When things become too much for a peer to hold, how do we connect our supervisor? How do we get in some of those clinicians? Talk about alternative approaches to care. And then, of course, in post-crisis, we talk a lot about planning, the importance of ongoing support. What kind of plans are we developing so that this doesn't happen again? What can we put around ourselves to protect ourselves and to find wellness? We also talk about system integration, the sequential intercept model, the specifics of Marcus Alert and 988 as we know them, and of course our own Compassionate Crisis Care Network, this kind of branch out of these peer-run groups, the clinical groups, and how we connect to services that are right in our own communities. If we know enough about who we are interacting with and their needs, if we take the time to figure that out, we can make some really good resource connections. And then, of course, the resources and citations and resources for greater crisis connection. So that's what we're developing. I'm working on a facilitator manual now, hope to deliver that training soon. And if you all have any questions about compassionate crisis care in our network, please feel free to contact either one of us.
Yeah, great. Thank you guys. I really appreciate that. I will absolutely, if you can send me those flyers, I will make sure that they get out. I'll send them to all of the regional coordinators and see if there's a way I can put it into this email thread for this invite. I really appreciate, all the hard work that you guys do. It's great to see that enthusiasm on the ground level, because it really does make a difference in how individuals engage with our new crisis continuum, or a continued crisis continuum as it's being developed. So thank you guys.
Thanks, Emily.
Yeah. Okay, so we have a lot of really, big news and leeway on the Marcus Alert training that has been asked. I do also have our vendors on the call as well. If at the end there are questions specific to the training that you would like to speak with the vendors or hear anything from them, they said they would be available. So we are really on the final stages of the advanced Marcus Alert training. I think the curriculum has been finalized, and the PowerPoint, and the big pieces are done. At this point, we are just wrapping up facilitator guides, and some extra work on how are we going to provide this material to the individuals that would be taking the course, and just kind of other smaller nuances. So a little bit of information on what this advanced Marcus Alert training is going to be. It will be for one.
Hey, Lisa.
It's a 1 day, 8-hour training in person. It's going to be available for all behavioral health, 911 dispatchers, and law enforcement officers who are interested. I know that there are some requirements per code on which law enforcement officers are required to take the training. I think it's those that are 40,000 or more, but we are not going to turn away any law enforcement agency that's interested in taking this course. Sorry, 1 second. All right. And the content, it goes into a lot of things. It kind of touches on the intersection or intersectionality, the goals and the values that are kind of the spirit of Marcus Alert. How can we provide humane care, compassionate care to individuals in crises? It goes in depth to answer a lot of questions or confusions about the legislation, what is required, what's not required. It breaks down a lot of the protocols. It has participants go through the triage. You're given mock scenarios that you have to decide what Marcus Alert level that can qualify for, and how would you respond in each of those. So it's really robust. It covers a lot. There are some components of it that have a CIT feel to it. The difference really is focusing more so on the goals and values that are Marcus Alert and how that differs from CIT. And that's really making sure that we include that intersection of providing humane care or compassionate care to individuals that are of different backgrounds. So we're really excited to finish that, and we are going to hold in each of the regions train the trainer sessions beginning in April and May. It will be between those working under the Marcus Alert system at DBHDS, and well as those at DCJS, to make sure that we're covering both law enforcement and behavioral health. Again, we're still working on finalizing some of the other nuances, but we would anticipate that we can start allowing individuals to register for the training come towards the end of April, end of the summer. That would be our goal. but we will make sure that the regional coordinators have all of the information necessary for class registration and the schedule within each of the regions. So we're not quite complete on everything, but we are close to completion, and we should have that available for participants within the next 6 months or so. In addition to that, we are working on partnering with state colleges to research this training. We have just begun the process of figuring out what potential contracts would look like and research measures and so on and so forth. But I think where we're at, it's going to be evaluating for 3 years this training to understand the efficacy. It would be mixed between a survey at the end and then well as in-person interviews immediately following the training, the completion of the training, but also 3 months post. And then, towards the end, the idea was for us to also create a model about mental health in BIPOC communities from what we have learned. So again, all of that is very in the infancy stages and will be updated as it comes in. In addition to the in-person training, though, we are working with the same vendors to develop an e-learning specific for 911 and 988 interoperability. So it will cover some of the same concepts and topics of the advanced Marcus Alert training, but it will go a little bit more in depth on operations that are specific for 911 dispatchers and 988 call takers. So we are also just in the beginning stages of that, creating an outline and, picking and choosing what is important to have in there for both 988 and 911. So yeah, we're really excited about what is to come for these various trainings and research opportunities, and hope that it can help individuals that are in the field that are doing this work have a better understanding on how to help individuals navigate through the crisis system. And I will turn it over to our regional coordinators. So Erica from Region 1, whenever you're ready.
Hi, everybody. You can go ahead and flip to the next slide, Emily. I just like to kind of set the table for everybody to kind of remind you what Region 1 looks like and where we are. We have 3 CSBs who are implementing Marcus Alert right now. Encompass Community Sports since December of 2021, Rappahannock Area since July 2023, and Horizon since July 2024. And then also really important in some coordination is our regional office, which is in Region 10 in Charlottesville. They do a lot of support and behind the scenes work for us. So each of these CSBs, a little different than some of the other areas, they each have 5 PSAP dispatch partners. They each have numerous participating law enforcement agencies that they're coordinating with, and they also have several institutions of higher learning that they're coordinating with as well. And all of these CSBs have extremely rural areas that they work in, as well as suburban and urban centers. So we cover a whole gamut of types of communities that we're working with over here in Region 1. You can go to the next slide. So again, I said that there's a great deal of support that the regional office provides to us. They coordinate all of our mobile crisis teams are coordinated through the regional office. And in Region 1, we have local CSB teams that are working. We also have some regional teams that are out and about. And we also have private providers that are working, and the regional office make sure that all those folks are trained and on the same page. They are also, our 988 center is contracted through there, and so they provide a lot of support when we have concerns in, just the growing pains of communication between 911, dispatch folks and 988, and sorting through, a variety of challenges that come up. To that end, we also have a quarterly newsletter that is distributed through our regional office called the Status Report, that is sent out to all of our 911 centers, kind of just, again, letting folks know what's going on, and, some challenges that we've had in certain areas and how we've resolved those. And then I'd also like to give a shout out to the CIT coordinators across the region. They are not, housed in the regional office or in their individual CSBs, but they have been so instrumental in communication and coordination, especially as we're getting ready to do the train the trainer for this new Marcus Alert training that Emily was just talking about. They've been really great. So we can go to the next slide. So Encompass is our CSB that's been implementing the longest. And so they currently have been expanding their co-response program. They now are responding. This is the first time in this update that I'm able to say we're responding to calls 7 days a week. It varies across, remember I said we have a large area there that we're covering, so it varies across different localities, what hours are being covered, but between 8 a.m. and 8 p.m. And 7 days a week. They have 3 full-time, 1 part-time mental health co-responder who is partnered with CIT. And again, in our area, it is not a dedicated individual law enforcement officer with 1 mental health responder. The mental health responder responds with whatever law enforcement partner is available at that time. And again, they're responding to level 2s and level 3s and welfare checks. And they also have the ability, when things come in off hours, to do follow-ups with the folks in the community who need that extra support. Our mobile crisis program is continuing to be built out as well, and it's currently available weekdays from 8 to 4. And then we also here in Encompass have an overdose response unit. And that team is working within the crisis response program. And they receive referrals from EMS, from fire and rescue, as well as internal referrals from the co-response teams and crisis services. And that team is 4 peer recovery specialists that work to connect individuals and families to the helpful resources across the various communities. They also do a lot of work in distributing harm reduction kits across our area. And those of you who've been attending this meeting for a while will recognize our C Recovery Center. Every time I have a chance, I like to tout what's going on there. It is our peer-led drop-in recovery center which there's no barriers. You walk in the door and you are helped. So you don't have to have insurance. You just walk in the door. And there's a variety of resources that are available to you. And it's this center that kind of underpins a lot of what goes on in crisis response and really crisis prevention in our community. And so you can go to the next slide. Oh, One last thing I wanted to say about Encompass too, they hosted this Frontline Academy and invited folks from across the region to come as well. And the Frontline Academy focuses on providing guidance and training for mental health clinicians that are responding out to homes and places in the community. And it was an excellent training that was hosted by Encompass. You can go to the next slide now. So in Rappahannock area, again, they've been implementing since July 2023, and they also are expanding their co-response program. They started out with a co-response team in Fredericksburg, and that team was up and running actually before their Marcus Alert implementation. That program, has had some staffing changes, and so they now have a vacancy for co-response in Fredericksburg. But we have Spotsylvania's team up and running since July 1st of 2024, and there's also a position that's been hired in Stafford, and they will be getting going very soon. The community stabilization is expanding and now available for children and youth. The CIT program in Rappahannock area has added a Marcus Alert presentation to their curriculum, which has really been an excellent forum to hear back from frontline law enforcement who's not necessarily participating in the local Marcus Alert meetings about what's working well in their agencies in relation to Marcus Alert and what's kind of needs adjustment and improvement. And then that's allowed us to have some really more full discussions and build some resolutions. So collaboration is continuing here with monthly meetings, quarterly meetings with the with HopeLink. Again, these were the ones I had spoken about a little bit earlier that the regional office has been really helpful in coordinating, and it's been a great problem-solving space. So next slide. Horizons been going since July of 2024, so they're our newest area. They have recently hired a licensed mental health provider, which is expanding their capacity of their local mobile crisis team. Horizon also has a community response team, which is a team of clinicians and peers who receive referrals from Lynchburg Police Department and then follow up to assist people and link them to services. And they have been, so it's not a co-response team. It's not a mobile crisis team. It's it kind of in between. And so they have been active since late September. Then through a COPS grant, Lynchburg has a co-response team, and we have staffing turnovers like everybody else, and so there's a vacancy for their co-responder right now, and they're looking for a good person to fill that. And then Horizon has been long working on building their crisis receiving center, and it's very exciting because they've moved past the demo phase and walls are going up. So we're going to keeping moving forward there. Horizon CIT program, again, another integral piece, especially, Emily mentioned they're building out a training for 911, 988 folks. And in this area, those folks were very concerned that they didn't know enough. And so the CIT program really responded and upped their dispatch trainings and are continuing to offer that. And finally, again, a lot of collaboration and leadership at Horizon in facilitating discussions when the partners have, faced challenges with their triage system through the first quarter, and we're able to, put together meetings of the right people so that we could get everything resolved. So that is what is going on there. So the next slide is just contacts if people need to contact individuals. But what I really would like to highlight is just it's so vital to have good communication, good collaboration all across our region. Individuals and agencies are always eager with the next people implementing to help them so that they don't have to reinvent the wheel. And it's just so important for that collaboration. So that's what I've got from Region 1.
Great. Thank you. I appreciate it. Lots of things happening for you guys. All right. And then we have Region 2. I'm not sure if Wendy or Stephanie is going to present, or maybe a combination of the two.
It'll be me. Hi, everyone. I'm Stephanie Pryor with Region 2. As of July 1st, all of our 5 localities have implemented Marcus Alert, with some of our localities entering into their 2nd and 3rd year. So I'm just going to go through county by county and provide updates. So our first, Arlington County, they continue to work actively with the community and community partners in their 1st year of implementation. They implemented this past year, July. So for community engagement, the Arlington Marcus Alert team provided education at over 10 community events and interviewed with 2 local news stations on the development of Marcus Alert in the region. For marketing, Arlington hired interns who created infographics and an outreach resource list, and Arlington County created a Marcus Alert landing page on the county's website. And for training, Arlington County trained over 117 first responders in 2024. I'm going to go through some fun, Nexus data. Okay, Arlington County, as I stated before, it implemented July 1st, 2024. And they continue to use their funding to fund their mobile outreach support team, or MOST. And the team continues to expand into the new year, and they plan to hire additional staff and extend hours. Next slide. Okay, so fund data. From July 1st to January 31st, their PSAPs received 435 identified mental health calls. Of those calls, 59 calls were identified as level 1 and 2 and were supported at the Regional Crisis Call Center. 358 calls were identified as level 3 and handled locally, and 18 calls were identified as level 4 and handled locally. Next slide. So City of Alexandria, they continue to expand their Marcus Alert initiatives. They launched their post-crisis outreach team in November. For that team, current client referrals come from the CSB Emergency Services and Alexandria co-response teams. And they hope to expand their referral sources in the future to police and fire and rescue. In the first 2 months of implementation of this program, they received 28 referrals. Okay. As previously reported, in August, Alexandria used their Marcus Alert budget to fund multiple CSB positions, including a Marcus Alert coordinator, outreach case managers, emergency service staff, and for training of PSAPs and CSB staff. Okay, data from July 1st to December 31st, PSAPs received 1,716 mental health related calls. Of those, 56 calls were transferred to the Regional Crisis Call Center. 549 received CIT responses, and 639 received co-responder team responses. Moving on to Loudoun County. Loudoun County also implemented July 1st, 2024. They continue to work closely with Loudoun County Fire and Rescue, Loudoun Police Department, Northern Virginia Community College. And they also used their Marcus Alert funding to fund their co-responder team. Data July 1st to December 31st. They received a total of 665 calls. 394 were labels level 1, 121 were labeled level 2, 111 were level 3, and 39 were level 4. And also of those calls, the Marcus Alert responses were 155 received co-responder units dispatched, 15 received fire and EMS only, 154 received law enforcement only, 20 there was no transfer dispatch, 291 received specially trained law enforcement only, and 30 were transferred to 988. Okay, moving on to Fairfax County. Fairfax is in their second year of implementation, having fully implemented since July 2023. They continue to cross-train all staff within the crisis response system, including sheriff, fire and rescue, police, 911, community response teams, co-responder teams, regional mobile crisis teams, and CSP mobile crisis units. Some of their data from July 1st to December 31st, 321 calls were transferred from PSAPs to 988. 1,379 contacts were made by co-responders, CSB mobile crisis units, or community response teams, and 2,849 responses by CIT officers. Level 1 and level 2 labels, 60% of behavioral health related events were marked as a level 1 or a level 2. 6% of the calls were transferred to 988 by Fairfax PSAPs. And currently on calls, PSAPs are confirming that there's no imminent risk. They're educating the individual on 988 and completing warm transfers to 988. And in the community, first responders are educating on 988 and providing HopeLink cards. Okay, and last but not least, Prince William County implemented July 2022. As previously reported, they used their Marcus Alert funding to pay for positions for their outreach and engagement team, vehicles that are used by the team, and to fund the regional coordinator position. Also, as previously reported, they used their Marcus Alert funding to outreach the outreach and engagement team. Prince William County has 6 locally funded co-responder teams that consist of a certified pre-screener and a Prince William County police officer. And these teams are dispatched through 911 for behavioral health emergencies. Okay, and some data between July and December, Prince William PSAPs transferred 444 calls to the Regional Crisis Call Center. From July to September, PSAPs received 62,019 calls. 1,409 calls were labeled a Marcus Alert level. 1,053 were level 1 or 2. 356 were labeled level 3 or 4. And from July to December, Prince William had 433 co-responder responses, 106 ECOs with a 76% diversion rate, and 2% in incidents where force was used. And from July to December, Prince William County had 378 outreach referrals, 532 regional mobile responses, and 145 Prince William County mobile responses. And some data from our Regional Crisis Call Center here in Region 2. From August to January, there was a total of 1,096 diversion calls from Region 2 PSAPs to the Regional Crisis Call Center. And dispatches to Region 2 mobile crisis response from all dispatch sources. There was 715 referrals made, 105 were canceled, 53 were unable to assess, and 557 were completed. And dispatches to Region 2 mobile crisis response from HopeLink. This is between August and January. 255 referrals were made, 38 were canceled, and 19 were unable to assess, and 198 were completed. And those are our updates from Region 2.
Awesome. Thank you, guys. All right. And I will pass it off to Chris for Region 3 updates.
Yes, ma'am. Thank you. Chris Parks, Region 3 coordinator for probably another few weeks before we transition somebody else into this position. Um, very, very firm believer in numbers because that's how we know it works, right? So just to go through, first off, I will piggyback on what Eric has said to begin with. CIT is such an important part of Marcus Alert. Uh, you know, Marcus Alert and co-response and the field version is just an extension of that CIT program for us. I think that Mandy Lee, who is the coordinator for BRBH, and Joey and Patrick at New River will tell you the exact same thing. The cool thing about the system we have in Region 3 is when that co-response unit goes out into the field and they engage with that person in a mental health crisis, and they voluntarily get that person to come back to that crisis center, and they hand it over to CIT, and then they either go to the 23 or they go to the CSU. That's how the crisis system is supposed to work, right? Not necessarily going to the hospital, not going to the ER, just that more therapeutic environment. And I really think that the reason that Region 3 has such good success right now with Marcus Alert is because of that strong CIT foundation. Okay, so just going through some numbers really quick. I won't talk very long at all. But Highlands Community Services, that was the first one up in Region 3, been running since about November of 2022. There are two full-time teams, two deputies, two clinicians, and one peer that splits both of those teams. So very good presentation with the peers earlier. They are worth their weight when it comes to our co-response program here at Highlands. Additionally, I'll skip down a little bit. We run 12 hours a day, 7 days per week. What happens when those two deputies and clinicians need to be off? We also have 11 PRN deputies and 7 PRN clinicians who can fill in so we do not have a lapse in coverage when they need to be off. Down at the bottom there, 745 triaged calls. That means a call that has came in to the PSAP, whether that be Bristol or Washington County. That's who Highland serves. 748 calls were actually triaged one of those Marcus levels. Additionally, there were 934 other mental health related calls. That's since the inception in 2022. My math's correct. That's about 1,700 calls that these teams have answered since 2022. Okay, you can move forward. A few more numbers in fiscal year 2025. That's July to now, current, right? 339 hours have been saved, 548 calls for service with 338 hours saved law enforcement partners. I don't really like the term saved because those our co-response units, when you're a law enforcement officer and you're on the road and you're out here answering calls, your goal is to get to the next call. You have them backed up and stacked up, and you just want to get through it. The co-response guys, if you look at that 339 hours, they're spending close to 30, 45 minutes on a call. They're able to actually give that person in crisis the time that they need. Okay, I think that's very important. 11 of those interactions resulted in a paperless ECO by one of the teams. And then the teams have also assisted other law enforcement agencies with 18 ECOs. One of the things that I know Highlands is very proud of, and the other CSBs also in Region 3. If you look at that at the bottom, 0 incidents of use of force by those co-response teams over that span of 1,700 calls. Okay, move forward. Just some of the some pictures from the Highlands teams. They attend community events. The picture in the, I think it's top right, is a training day where we had all of our law enforcement partners from different agencies there helping us train. They give out backpacks to the homeless in different parts of the catchment area. They've done food drives with the local community college, things of that nature, along with attending community events. Okay, next slide. All right, Blue Ridge. Their program looks a little bit different than the one at Highland. the program at Highlands or the program at New River, they have 4 clinicians or therapists that respond alongside law enforcement or will respond after law enforcement calls them to the scene. They serve a huge area, a very populated area for Southwest Virginia. That's Bonnetoc County, Roanoke City, Roanoke County, Salem PD, and Vinton PD. And these teams actually provide 17-hour coverage 7 days per week. You can move. And then for the year, the clinicians from BRBH have diverted 329 cases out of 610. That's a pretty good diversion rate of 54%. And then teams have saved approximately 2,632 hours for their community partners. And you can move forward. And this is some of the training that those clinicians do. Their clinician academy and then attending community events. And the top middle there is Officer of the Month that one of their co-response officers was able to obtain. Okay. And then last but not least, as far as implementation for Region 3 is New River, who came on board in July of 2024. They do a lot with a little in New River. They have 5 teams, each consisting of a law enforcement officer and a clinician. And these teams serve Blacksburg, Christiansburg, Radford, Montgomery County, and the campuses of Radford University and Virginia Tech. They provide 14-hour coverage 7 days per week. Okay. And then from July through December 31st, teams have answered 389 calls for service, 289 hours have been spent across those calls. 38 have resulted in an ECO. Again, it works. They have that strong CIT foundation, so they're able to divert those folks into to the right place that they need to go. Again, I said earlier that they're probably most proud of that last bullet point there. Over those calls, 0 incidents of use of force. Now, my law enforcement people will probably, knocking on wood, and would probably hit me right now for saying that, but that we'll deal with that later. So next slide, please. And these are just some of the pictures of the co-responder week for that New River celebrated with their co-response teams. Some of those pictures of them out into the community. So, and that's all from Region 3.
Awesome. Thanks, Chris. We appreciate it. You guys definitely show the love for co-response in that region, and it's great to see. I will turn it over for Hannah to talk about what's happening for Region 4.
Thanks, Emily. All righty. We can go ahead to the first slide. All right. Hi, everyone. My name's Hannah Newkirk, as Emily shared, and I'm the Region 4 Marcus Alert Coordinator. Excited to share some updates from our region, and just always appreciate these statewide meetings to hear updates from other regions, and always appreciate the help of other regions and localities in sharing really vital information when it comes to Marcus Alert implementation. I think a theme we've already heard in all of our brief presentations is just the importance of collaboration, and that's within localities, within regions, but even across the state. So I'll just give some brief updates from each of our localities that have implemented, cover some regional crisis call center data from the last half year, and then show a snippet of our new crisis services transformation video. So to start out, just so you all are aware of what Marcus Alert implementation has looked like in Region 4, this is a timeline here. At the top, we have the city of Richmond. That was the first locality to implement Marcus Alert back in 2021. Second was Chesterfield, and they implemented in 2023. And then we have most recently Henrico, who implemented this year. And currently, Hanover is in their planning phase, scheduled to implement in 2025. And I'm just giving some very, very brief updates from Richmond, Chesterfield, and Henrico, who are the 3 localities that have implemented, focusing on their current response models. So starting with Richmond, Richmond's current response model includes co-response. Their co-response team is called CRT, or Community Response Team. And for this team, their clinician rides along with an officer. They currently are operating one full-time team. This is due to some workforce challenges that I know are felt across the state. And an additional component in Richmond is what's called their community focus team, or CFT. And this is a team made up of a clinician and a certified peer recovery specialist that conducts community outreach and follow-ups from referrals that they get from the co-response team. And then just some very brief data highlights from the first half of fiscal year 2025. This one team conducted 211 responses over Q1 and Q2 with a 92.89% diversion rate from involuntary hospitalization and arrest. You can go on to the next one, Emily. Thanks. And next we have Chesterfield. So similarly in Chesterfield, their co-response model includes clinicians that ride along with officers. They currently have 2 full-time teams. And an additional component in Chesterfield includes what's called their sprint team. And this is a joint effort across behavioral health, law enforcement, social services, and other systems and services to provide prevention and follow-up care for those with behavioral health needs that interact with the emergency response system. And some data highlights for Chesterfield's teams. In the first half of fiscal year 2025, they conducted 276 responses with a 79.35% diversion rate from involuntary hospitalization or arrest. And then finally, for the local updates, we have Henrico. So Henrico has 2 co-response teams. And those teams, like Richmond and Chesterfield, a clinician rides along with the officer to respond to calls. Henrico actually also recently launched civilian teams, or non-law enforcement teams, of clinicians and peers. And some additional components in Henrico also include what's called their STAR team and CARE team. And so STAR is their interdisciplinary follow-up and prevention program that addresses more complex needs of folks that interact with the emergency response system. And this started back in 2012. So they've been operating this for quite some time and really was one of the first of a kind in Virginia to do so. And then their CARE team is a team within the Henrico Division of Fire that provides wraparound support to individuals with unmet needs in the community. And then for data for Henrico's co-response teams, over the first half of fiscal year 2025, they conducted 298 responses with a 79.53% diversion rate. And just overall, with all of these localities, wanted to emphasize that the teams really work tirelessly to respond to individuals, despite ongoing workforce challenges and resource limitations. They, on a daily basis, are de-escalating crises and diverting folks from more restrictive levels of care. And so I wanted to highlight here, to just take a slide to brag on these teams a bit more and show a few articles that were all published within the last 6 months on the Henrico, Richmond, and Chesterfield co-response teams, but also on our regional mobile crisis response operated by CREST. And so these articles highlight really the on-the-ground vital work that these teams are doing, often unseen work, to provide the most appropriate care to those experiencing mental health crises. So when y'all receive these slides, if you'd like to read the articles, just click on the pictures and it should link to the articles. And then just giving one slide here to cover some major data highlights from our regional crisis call center. So that's in our region, the operator for 988, who is HopeLink, who I'm sure a lot of the folks on the call are very familiar with. They're incredible partners in our region and for 4 of the 5 regions in Virginia. So in fiscal year 2025, first half of that fiscal year, so again, that's July through December, The Regional Crisis Call Center received 58,861 calls, which represents 43% of statewide 988 calls. And as you can see by the graph on the right, calls to 988 in our region have continued to increase in the past half year. They've increased by 76%. And that increase is due in part to the expanded awareness about 988, but also due to a process change that took place back in December of 2023, when the regional crisis call centers in our state became the primary avenue for processing and dispatching mobile crisis response in our state. So related to that, in this past first half of the fiscal year 2025, there were 15,380 mobile crisis responses completed in our region, Region 4, which the vast majority of which occurred in the city of Richmond. And this is a 68% increase over this first half of the fiscal year 2025. And for some context there, this disproportionately high number can be attributed to a number of factors, including the high concentration of private providers in Region 4, the misuse of mobile crisis response service by some private providers, and the ongoing housing crisis that's really inextricably related to mental health crises. So understandably, due to this volume increase, answer rates, as I'm sure you all might know who are doing this work on the ground, answer rates have suffered a bit. And as hopefully you all know as well, there have been really consistent and collaborative efforts made to improve answer rates, both at the regional and state level. Just wanted to highlight that and all that's being done behind the scenes to work on that. And then finally, I just wanted to share a brief clip from a video. So in the past few months, myself and others in my department have worked with representatives from our regional crisis system stakeholders to create and distribute a brief video to enhance understanding of all that's changed when it comes to regional crisis services and the crisis continuum in Region 4, but also in our state. And so the full public version of this video is linked here on the screen if you'd like to view it. But if you go to the next slide, Emily, I'm just going to show a brief 20-second clip of the video.
Yeah, I'm going to stop sharing just for a second because I don't know if I turned on the capability to also include the audio in it.
No problem.
So let me just make sure before include sound. Okay. Well, let's see. Okay, so I won't be able to play it with the audio because I recently got a new computer and it won't allow the sound, but we can watch it.
That's okay. I don't think there's captioning, so I don't know if or you could press closed captioning and see if that works. If not, oh, that did work. Okay. Well, we can view this short clip, and then if y'all are interested, you can definitely just click on the link and see the full one on YouTube.
While there are many crisis programs available in our region for both children and adults, there is no wrong door for accessing care. This means that any of the regional crisis services can connect you with the most appropriate level of care.
Awesome. Thank you. And sound mostly worked. So that is it for my portion of the presentation today. And just I think the last slide just gives my email address. If folks have questions, feel free to contact me. But happy to be here. Thanks, Emily.
Thanks, Hannah. That was great. I appreciate that. All right. And then last but certainly not least, I will pass it off to Claudia for her so she can give updates for Region 5.
Hello. I'm always the last, but like she said, not least. As you guys may know, this region, which is normally not the one to report out that we've been shut down by weather, but we've had a lot going on since the new year has come in. But I got a report together anyway, even though half of us have been off work for days. So stand by, and if you have questions at the end, of course, the coordinators for each of the locales that I'm reporting on, they can chime in if I have done something, missed something important. So I guess just wanted to give you a snapshot of what Region 5 looks like as far as implementation is concerned. Of course, we have 3 locales that have implemented, with Virginia Beach being the most senior, implemented in December of 21. And they continue to have a long-standing mobile crisis team that responds and is well received in the community. They're fully staffed. They pitch in for our mobile crisis team that has been short staffed, just filling in wherever needed. So we run like a well-oiled machine. Of course, nothing is without hitches, but Virginia Beach is still swinging along and doing just great. Hampton Newport News, they implemented in July of 23. They have 2 care teams. The team includes a behavioral health clinician and an EMS worker. And there's a CSB team with a police department co-response. And they have hours, as you can see here, Monday through Friday, and varying shifts on the weekends. And I do believe that they implemented an overnight on one of those teams. I want to say it was on a Tuesday night. And they are looking to add another care team in partnership with the Hampton Police Department, Hampton Fire Department, and the CSB, as well as Centera. You can go to the next. Western Tidewater, they're the youngest. They just implemented this past July. They have a beautiful co-response vehicle that all the region is jealous of. I wish I had a picture. I don't have a picture. They have hired a full-time clinician. The calls and dispatches are continuing to increase, and they're well received in their community. They implemented the paramedicine model with the Suffolk Fire and Rescue. So we continue to grow. I'll say that there are 24 PSAPs and 14 are signed on with our hub. And I just wanted to put a chart up here of the growth that we've experienced over the past 3 years. This was compiled by Casey Mewborn, who is the regional hub program supervisor. Just looking at dispatches from 22, which the total for the year was 704, and it's more than tripled to 2024 with 4,464. And you can see how they break down by locale with 78 in 22 for Chesapeake, and they're now 448. Colonial, 29. They've more than doubled with 82. Eastern Shore, which we know is very remote. They had a bigger year in 23 than 22, doubling, and they're now at 24. Hampton Newport News, they take quite a bit, from 125 to 1523. Middle Peninsula, 30 to 61. And Norfolk, 122 to 866. So they've tripled. Portsmouth, 37 to 307. That's a lot of growth from 22 to 24. Virginia Beach, 169 to 609. Again, more than tripled. Western Tidewater, 94 to 481. So we continue to grow. That's what we want to see. You can go to the next slide. And again, this is just how it all breaks down. Level 2 621 in 22, level 3, 31, 44 for telehealth, 403, 269 face-to-face, and law enforcement involved, 123, and where they needed 10 of those calls they were needed. And we just want to, this just kind of shows that whatever the help that is needed, it is available. Crises do happen, but Region 5 has been prepared to answer those calls. And you'll see that in 24, again, the biggest number is level 2, which is pretty good. That's what you want to see. And 452 where the law enforcement was involved. And the goal, of course, is to have as minimal law enforcement need to be involved as possible, but to be available should they be needed. So we're really proud of the growth that we see in Region 5. That's it.
All right. All right. And well, we ended a couple minutes early. So we can go ahead and open it up for questions if anyone has any that they would like to ask. I don't know if there were any in the chat. Okay, so there's some. So in the chat, someone had asked if the co-response data that is going to be beginning April 1st, if it was supposed to be backdated as well, and it's not. No, it will not be. It will start April 1st and it will continue on. So every CSB that comes in and has and develops a co-response team, they will have to collect this data going forward, and all of those that have already established co-response team beginning April 1st, it will start there and then go forward, but you don't have to backtrack. Just reading through some to make sure I didn't miss any questions. Okay. Teresa Champion, would you mind sharing a little bit more detail about your question? What are you specifically asking regarding the REACH and DD? What program? I wonder if she got off the call. Okay, Brian.
So yeah, that's from Teresa and me. So our concern is, are you coordinating with REACH? Because the REACH seems to be the place that people with autism are sent to, and just want to see what the coordination is between them and 988 response teams.
Yeah, so regionally in mobile crisis, the regional hubs communicate directly with REACH. I think even in our VCC platform in which mobile crisis is dispatched, there's that component for REACH to be included in that. So typically there's it's done through like the behavioral health platform for the mobile crisis and regional center hubs to collaborate with REACH.
And in addition to that question is, there's some great work I saw going on at all of the different regions. I wanted to see what work is being done to address autism in these situations, in these crises, that when they're having, autism mental breakdowns, for instance. Do we have people that are trained specifically in autism to address these?
So we don't have anything specific to autism. In part of the development of the mobile or in the Marcus Alert training, We do include scenarios, so each of the participants go through various role plays, and autism or neurocognitive diagnosis is included in that for them to have to navigate the various outlets within the crisis continuum for individuals who may have an ID or DD component. Usually it is that we defer to REACH, usually law enforcement officers or behavioral health professionals would defer to REACH, and I know like that's required by law for pretty much any of those circumstances. But in the initial engagement of the behavioral health crisis, we help them, and I think it's also a component of CIT as well. Like, how do you de-escalate for neurocognitive disorders?
Okay. Because the Marcus Alert was also in conjunction with people with developmental disabilities as well as people with mental health crisis. So
Yeah.
I want to see how that was being addressed. So I appreciate that.
Yeah, yeah. Yeah, it's more, boots on the ground moment, not long term on handling what is the signs and looking and identifying what signs of neuro cognitive disorders and how the de-escalation techniques might be different compared to an individual that may not have one of those diagnoses.
Okay, thank you.
Yeah. I see Nikki asked, with potential budget cuts to Marcus Alert, is there any indication on what areas will be built out and which will not? Yeah, that's something that we don't have an answer for right now. We won't until we have the finalized budget signed by the governor, so we actually know what our funds are, what our capabilities are. And so that would be something that we'll plan and have discussions on internally before we reach out to VACSB and other, necessary stakeholders to readdress or maybe redefine the schedule for implementation. Yeah. So, Christina wrote in here, we're looking for lessons learned and experiences with dispatching clinicians only teams from PSAP. If you know, or if you are doing this, please let her know. She would love to learn. She gave her contact there in Fairfax. So that would be great. Some collaboration. Any other questions, comments, or concerns? We gave kind of a lot of updates. Most of it kind of pending on completing data requirements, completing training modules, completing the finalizing of the fiscal year budget. But anything else that comes to mind? All right. Well, we have our contact information was on the screen. I'll email the PowerPoint slides to the regional coordinators. So if you need or want to have access to those, please feel free to reach out to the coordinator within your region, and they can share that with you. But if you have any other questions, feel free to reach out to myself or anyone else at DCJS or WHDS. All right. Take care, guys. Thank you.
Thank you.
Thanks, Emily.
Thank you all.